All right, so this is a quick voiceover over the remaining part of the lecture from DKA and HHS that we didn't get to on class on Wednesday. So if we did a comparison between DKA and HHS, remember DKA more commonly occurs in patients who are type 1 who have a absolute deficiency in insulin. It's usually going to occur very quickly over 1 to 2 days. We know it's typically associated with an infection, new diagnosis, or maybe surgery. Usually the blood sugar is going to be greater than 250. Sometimes it can be up into the 600s, 700s. Their pH is going to be less than 7.35, right? That indicates acidosis. So with DKA, they have an accumulation of ketones, sometimes an accumulation of lactic acid if they're severely dehydrated or their blood pressure is low and it alters perfusion. Their sodium bicarbonate level is going to be less than 15, right, because of the increased acid production of ketones, possibly lactic acid. So there's going to be a relative, not an absolute decrease in bicarb. If we check these patients' blood urine, they're going to be positive for ketones, but usually we don't continuously monitor inpatient for ketones. We'll look at a chemistry panel. And this is not appropriate for you to remember for your exam, but it is appropriate for you to look at for practice. A lot of times they'll look at what's known as the anion gap. And we can get the numbers that we need to configure an anion gap right from a chemistry or a basal metabolic profile. So the anion gap is the sodium minus the chloride minus the bicarb. And anything greater than 12 indicates that the patient is still acidotic. And so a lot of times we like to see it less than 12, and we refer to it as closing the gap. All the anion gap is just a way without checking a blood gas, because we know we have to stick these patients arterial. It's just a way for us to more easily check for acidosis than without actually checking an arterial blood sample. So we want the anion gap to be less. We want it to start closing. And the configuration of that is the sodium minus the chloride minus the bicarb. So the gap is closing. So yes, less than 12. Greater than 12 would indicate a wide anion gap and the patient is still acidotic. Now HHS, very rare condition as well. It's typically going to happen in your patients with type 2, maybe older. These patients have some sort of infection, stimulates the release of the counter-regulatory hormones. So we're going to have excess glucose available for the stress response to fight the infection injury. But these patients are not going to be ketoacidotic because they at least have enough insulin production that the cells are not going to be starving and they're not going to have to break down free fatty acids for energy. It can happen more insidiously, so more over weeks. Okay, so sometimes if it's a gradual progression, we may not identify it until the patient gets severe. And as a result, some of their glucose levels can be up in the 900s, thousands. So that's another characteristic difference between DKA and HHS. HHS, their sugars are going to be higher because it happens over a longer period of time. They're not going to have acidosis, right? Because we're not breaking down ketones. So if they do have an acidosis, it's probably because of fluid loss, low blood pressure. But yeah, they're not metabolically acidotic typically, and there are going to be no ketones in their urine or blood. But they are going to be severely dehydrated. So we're going to see a high serum osmolality, and our serum sodium is probably going to be high, all indicative of dehydration, right? Fluid loss. So HHS is a life-threatening condition, right? Because of the dehydration, the severe dehydration, the severe elevations in the blood sugars. Like we said, usually infections, okay? Older patients. And the fluid loss can be so significant, not only because it's gone on for too long, but because their sugars are much higher with HHS. So if the sugars are higher, you've got more of an osmotic pool. So they're going to be urinating a lot, just as much, if not more, than DKA. And if it's happening with an older patient, we know that they have impaired thirst sensation, right? So they're not going to be drinking a lot with HHS as compared to they will with DKA, because we say, what are our 3 common manifestations with diabetes if their sugars are high? Polyuria, polydipsia, polyphagia, right? They're hungry, they're eating a lot, they're thirsty, they're drinking a lot, and they're peeing a lot. Just a pathomap of HHS. All right, so like we said, they've got enough circulating insulin to prevent ketoacidosis. Blood sugars are going to be severely high, and so there's going to be a lot more indications of dehydration. And we know when we have higher osmolality and a higher serum sodium, there's higher pooling pressure within the vasculature space and the interstitial space. So we can actually cause cellular shrinking, right, in the cells everywhere. So we can actually see neurologic manifestations, physical findings of dehydration because the cells are shrinking. So we can see confusion, altered level of consciousness. And like we said, ketones are going to be absent. However, we still might see effects of poor perfusion, decreased urine output, so AKI, pre-renal, hemodynamic instability, low blood pressure, other indications of hemodynamic instability, high heart rate with a lot of variability, cool, pale skin, decreased peripheral pulses. Like we said, manifestations of HHS, low blood pressure, tachycardia, indications of severe dehydration. So the urine output, they're having copious amounts of urine output, especially in the beginning, but if we're looking at it, I would say it's still probably going to be fairly concentrated. Glucose levels, 800, 900, 1,000. If we look at their serum blood, right, their sodium level is going to be high, greater than 145. Their serum osmolality is going to be greater than 320. All right, so like we said, it's rare, but it's a medical emergency because these patients, it goes on for long periods of time. They usually have a corresponding infection with it, which we know there's a high mortality rate with that in our older patients. And they don't have the thirst mechanism. All right, so what are we going to do for these patients? Well, we're going to do insulin, and yes, we're going to do fluid volume replacement. If you had to ask based on NCLEX, you're going to do insulin first. Yes, I said severe dehydration, but you also have to remember, why are they dehydrated? Because their sugars are high, and we said HHS compared to DKA, their sugars can be up into the 800s, 900s, and 1000s, right? So that's much more severe than with DKA. And so the only reason they're peeing a lot is because of these sugars. We need to get them down. So if we had to ask a priority question with HHS, we're going to give insulin first. And then we're going to give large quantities of fluid. Yes, same thing as far as like with DKA, crystalloids. However, we need to replace their fluids based on what the osmolality content in their serum blood looks like. If they're hypertonic, we're going to maybe give them a little bit of half normal. But we know 0.9% is isotonic. Yes, we're going to look at their sodium. We're also going to look at their potassium levels as well. And we're also looking at the underlying cause. If it's an infection, right? Antibiotics. All right, like we said, IV fluids, insulin. Yes, we're going to put these patients on an insulin drip, monitoring their electrolytes, potassium. We might see an elevated potassium because if they're truly dehydrated and it's an AKI, we might see an elevation in potassium. Or we might see a low potassium because they've just had so much diuresis. Hopefully, once we resuscitate these patients, it can correct this. But we're still going to need to monitor their electrolytes. If it's a high potassium, what are we looking at? Slow heart rate, widening QRS, lengthening PR interval. If it's a low potassium, PVCs, ventricular arrhythmias, atrial arrhythmias like AFib, A-flutter. Cardiopulmonary status, right? Not all older patients, especially if they've got renal disease, if they've got heart failure, can they stand massive amounts of IV fluids? So we need to be monitoring their cardiopulmonary status when we're rehydrating them, resuscitating them. What are their lung sounds like? What are their O2 sats? and then level of consciousness. Hopefully once we start to correct the osmolality and their electrolytes and their fluid volume status and the underlying cause of the HHS, we're going to have improved mentation. Just another slide that kind of breaks down. All right, so discharge planning. Yes, regardless of whether it's DKA or HHS, we're going to focus on their diet, especially if these patients are newly diagnosed or if they're just non-compliant. So yes, we're going to reinforce appropriate diet, but we also might encourage diabetes education, nutrition specialist. If it has to do with the insulin regimen, is it because their pump has malfunctioned, or is it a dosing error with insulin? Do they know how to take care of themselves on their sick day? Okay. So when do they call their physician? Should they be checking their blood sugars more frequently? What are the goals of our blood sugars when these patients are sick? Should they be taking more insulin? Okay. Definitely they're going to be taking their insulin even if they're not eating. Okay, right? We said we sometimes are going to need more insulin when these patients are sick from the stress response, counter-regulatory hormones. We also might consider knowing, okay, if this patient is type 1, do we need to be checking our ketones through our urine? Right? That may be an indication if these patients are at risk for going into DKA. So a client with type 1 diabetes has DKA. Which finding has the greatest effect on fluid loss? And I think the answer is clear because it's the only one that's appropriate, is the rapid deep respirations of Kushmal's. So not only are we losing fluids with the osmotic diuresis, but when these patients come in, we're losing fluid from evaporation, from breathing. So an unresponsive patient with type 2 diabetes is brought to the ER and diagnosed with HHS. The nurse will anticipate the need. We're obviously not going to give them dextrose. I like B. We're going to insert a large bore IV catheter. We're definitely not going to be looking to give them longer acting. We're going to give them shorter acting, regular insulin. And although I like oxygen by nasal cannula, nothing in the question asks us or tells us there's a respiratory issue going on, although we need to worry about airway breathing circulation. The bigger issue with HHS is high sugars, dehydration. So insert large bore IV catheter. So a 54-year-old patient is admitted with DKA. Which admission order should the nurse implement first? Infuse 1 liter of normal saline, give sodium bicarb, administer regular insulin 10 units IV push, or start a regular insulin infusion. So with DKA, we are giving fluid first, okay? So we're going to give 1 liter of normal saline per hour, okay? We're not always going to give sodium bicarb unless the pH is less than 7. We might consider doing regular insulin. We might give them a push. That was sometimes how we started a drip, and we still might give them a bolus, and we're definitely going to start them on an insulin drip. So the comparison between DKA, HHS, with DKA, you're giving them fluid first and then insulin, regular drip. With HHS, you're giving them insulin and then fluid. So a patient who was admitted with DKA secondary to a UTI has been weaned off an insulin drip 30 minutes ago. The patient reports feeling lightheaded and sweaty. Which action should the nurse take first? I think the most important thing to do is obtain a glucose reading using a finger stick. Why? Because we said that patients, as we correct them, we give them an insulin drip, we need to drop their glucose slowly. We want to prevent the shifts in fluid electrolytes, decrease the risk for cerebral edema, but we also don't want to make them hypoglycemia. It's a very real risk with having patients on an insulin drip. And the case scenario tells us the patient feels lightheaded and sweaty, which are characteristics of hypoglycemia. So check a sugar. So after change of shift, which patient will the nurse assess first? So a 19-year-old with type 1 diabetes who was admitted with Dawn phenomenon, common. 35-year-old with type 1 diabetes whose most recent glucose was 230. a 60-year-old with HHS who has poor skin turgor and dry oral mucosa, or a 68-year-old with type 2 who has severe neuropathy and complains of the burning foot pain? Well, clearly it's going to be C, the one with HHS, right? So a patient who is admitted with diabetes mellitus has a glucose level of 380, moderate level of ketones in the urine. As the nurse assesses for signs of ketoacidosis, which respiratory pattern would the nurse expect to find? Kushmal's.